I want to say hello and welcome to those of you who are coming into the virtual room. We are going to get started in just another minute. I apologize for starting just a moment late, but hopefully it gives folks a chance to all gather. All lines are going to be muted just to prevent background noise, but you are welcome to use the chat box or the Q&A feature if you want to be in touch with us. Just while we're waiting for folks to come in the room, when you're looking at the chat box, it's going to default to just sending a message to panelists. If you click the drop down and click panelists and attendees, everyone can see your comment. That would be great to do. Just to encourage conversation, we would love for you to share your experiences. So we'll get started in just a moment. All right, I think just for the sake of time, I'm sure we'll have more folks join us as we go, but let's get started. Hello again, and welcome to this webinar from the National Center for Equitable Care for Elders. My name is Ariel Mather, and I am the program manager of the center. Today's webinar is titled The Invisible Second Patient, Supporting the Family Caregiver. You may have registered back when we had a simpler title of Supporting Family Caregivers, but the topic is still the same, the content is still the same. Today's presentation is by our wonderful team member, Dr. Lynn Hollerman, who will introduce herself in just a moment. But first, let's briefly go into some housekeeping. If you're not familiar with our center, we do hope that you'll stay connected with us. We have been around for several years now, providing training and technical support to health centers across the U.S. as they care for their community dwelling older adults. We have several links to social media pages and our website. Feel free to click on those when you receive the slides after this session. And we have had for the past year an ongoing COVID-19 resource page on our website, but a fantastic resource in addition to that is the priority topics page in the Health Center Resource Clearinghouse that has updated information every day, every week or so, with especially vaccination information. I will also put a plug in for any health centers on the line today who are starting to vaccinate their patients. We are holding roundtable discussions for vaccine programs who are focusing on special and vulnerable populations, and you can find that information on the clearinghouse or on our website. We are all very familiar with Zoom reminders by now, but just to make sure we're on the same page, all lines are muted, but you have the option to chat with us both through the chat box and the Q&A feature. We are hoping to save a few moments at the end for questions, but if we don't get to a question, we will follow up via email with some resources. We will send folks a PDF of the slides after this session wraps, and you will have access to our YouTube page where the recording will be within the next week or two or so. We want to make sure that that's closed captioned. And once you close out of this Zoom link today, it will automatically bring you to a survey. We hope that you'll take a few minutes to give us your feedback. We'll also include that evaluation link in our follow-up email. And with that, I will turn it over to Dr. Hollerman.
Hello, everybody, and welcome, and thank you for taking an hour out of your busy days to join this webinar. I hope I will make it worth your while, and I'm gonna dive right in. Just in terms of what I'm gonna focus on for the purposes of this talk is really to look at unpaid family caregiving for persons community dwelling older adults. When family caregiving itself is a very broad topic it encompasses a lot of different kinds of situations, but we're really going to try to zero in on that, look at the stressors, and then how as a provider that you can support this population. So next slide. So I'm just going to say a few words about myself. So I'm a palliative care physician for over 20 years, and I don't think it's an exaggeration to say that I've counseled thousands and thousands of families, thousands of hours in family meetings. I work primarily in the hospital setting, so I've tended to see families in this sort of unraveled state because really, truly, family caregiving can be very destabilizing, and sometimes the way that that actually plays out is in a hospital admission. So I'm very familiar with dealing with families in crisis situations. I can tell you it's the easiest part of my work, because it really just active listening and validating can go so far with a family to do that for them. But on the other hand, it's also the hardest part of my job, because the situations can be so complex, and trying to actually do something practical for a family, it really does take, I will say, a team effort, and that's either in the hospital or out. You really need a team to work to do to help a family caregiver, and truly the system works against you to some degree, and we'll talk a little bit about that as well. Next slide. This is just a reminder that, this is a pre-pandemic numbers of aging in America, and there's been just this shifting older and older as time has gone on. I know with the pandemic, we've had a situation where we had something like in excess of 400,000 unexpected deaths, but we've also had about 300,000 or so unborn children this year, and like nobody wanted to have a baby this year. So who knows how that's going to shift our demographics. I mean, we'll find out. Next slide. Another just reminder slide to say that we spend a lot of money on healthcare in this country. A lot of it goes to hospitals, administrative costs, profits, laboratories, pharmaceuticals, not so much on supportive caregiving, and in all forms, not just for older adults. And, the general message in this country, unfortunately, is that you're largely on your own. And I also am going to talk about that a little bit later as well. Next slide. These are just some general numbers about how many people are doing caregiving. I'll be curious to see how the pandemic has sort of compressed and magnified and increased these kinds of numbers. And, we're also talking about all different kinds of caregivers for persons with disability and etc. So that's included in that number. And next slide. So I just wanted to bring to light this report that came out by AARP. It's a 2020 report, but if you're looking to sort of capture a lot of numbers in a snapshot of caregiving, it's a really excellent report. And go to the next slide, please. This is from that report. And I'm not going to go into detail, but all I want you to get out of that, if you look at the arrows, you can see all those arrows kind of going up, sort of suggesting that everything about caregiving is more and more and more. And this is before the pandemic. What you're going to see is that people are taking care of more than one person, that people are financially impacted, that you have people that are working full-time jobs, a lot of complications in caregiving that are sort of expressed in this chart. And the other thing they do in this report that's helpful to look through is simply sort of subdividing by different populations, socioeconomic, ethnicity, racial, all kinds of ways of seeing the way that caregiving impacts different groups. So I think it's worth just thumbing through. I wanted to bring it to your attention. So what are the factors that influence unpaid caregiving? Obviously we have an aging population, and that constitutes many of the people who need caregiving. But also, we have huge workforce shortages. I'm not going to talk about that a ton, but it's a job that's an unsung job. People are underpaid, they don't get living wages, the benefits are bad, the training opportunities are not great. And we ask so much of our paid formal caregiving workforce, but we don't give a whole lot back in the way of credit or support a lot of the things. So I think this is an area that needs just completely to be reinvented in our country, as far as I'm concerned. Very expensive to do formal caregiving. You really have to have a lot of money to have formal caregivers in your home, unless you're Medicaid eligible, and that also is a complicated pathway also. I think where community health centers come in with this also is just that we're shifting more and more in the community and away from nursing homes, although most people in the past have been in the community who need caregiving. But I think the pandemic has helped us want to move out of the nursing home setting. And I think community health centers have a really important role to play in this, and to be right at the table in terms of policy making and decisions. And I want to put that out to everybody that you really, this is your area. This is your bread and butter is caregiving in the community. Next slide. The pandemic, no question that it's unmasked many of the problems of caregiving. I don't think problems are new. I had a very formative experience working as a fellow in a congressional fellow about 2 years ago, where I looked carefully at nursing home care. And so when the pandemic came around, I was just sort of waiting for something terrible to happen with our older persons related to all this, because the system has been broken for a while, as far as I'm concerned, and many are concerned. And I think the pandemic has really brought that to light. So I'm hoping one of the silver linings of the pandemic is it really helps us to come, reckon some of these problems with caregiving in this country. Next slide. Just want to bring also your attention, much to my delight, if you went on the Joe Biden, on his campaign site, he actually has I'll say a aspirational plan for caregiving and education. That's quite, it's an easy read. I would read it because I believe he mentions community health centers. Yay! I was very happy about that. Just keep your eye on this, because it's the first time I've seen something so encompassing that's coming from the Fed this way for a while. So I would just take a look at it. It's brief. And next slide. Okay, I love poll questions, and I wanted to put this poll out to this group. I looked to see who was signed in, and I see a lot of social workers, case managers, administrators. This is really your bread and butter. But being part of having your own experience in caregiving and learning how to leverage that in a positive way. I just, for those of you who've actually been caregivers yourselves. So I don't know if the poll went out, Tiff. I don't see it up on my screen. If it didn't, it's no biggie. We'll just go past it.
Yeah, I don't see it either. I'm not sure if we're having.
Oh, there it is. Okay, so just click yes or no, and remember it's anonymous, so you don't have to worry about that. But I'm just curious on the call, although I can't participate, but I have been a family caregiver. I'm just going to throw that out there. No, okay, so 70% have not been family caregivers. Well, what I will say is that you will be. A lot of us will be. And it's interesting. Some people don't realize they do family caregiving also. Like it's a very weird term, and they think sometimes it comes out as being a good daughter, but in fact, you're actually a caregiver. So it's just food for thought. Okay, so next slide. So who is the unpaid caregiver? The only message that I have here is really to, when you're dealing with families on an individual basis, just not make assumptions about who actually is doing the caregiving. And if you've met one caregiver situation, you've met one caregiver situation. There's the iterations of it are kind of endless. When you're looking at an individual, we can make all kinds of generalizations about caregiver, which the AARP report does well. But as a system, we have a tendency to look for traditional structures with caregiving, the wife who's caregiving, the daughter who's caregiving, but we don't open up to that there's a wide range of people who can be involved in someone's caregiving, and you just have to sort of stay alert to that, or you'll just miss the situation. Next slide. So parent caregiving continues to be the main kind of caregiving that we're doing, and it's being done by generally women, not always, but generally women between ages 50 64 are doing the caregiving. So that's the lay of land, if you want a number around that, like who's getting the caregiving, who's giving it. Next slide. I've got another poll question. We'll see if this one. So what's the average amount of time an older adult will need caregiving? What do people think about that? Just something to recognize. Something to ask also, how long someone sees himself as a caregiver. I got to submit my answer, yay. So.
In the poll.
Okay, yeah, five. Actually, it's a little bit of a trick question because if you put in any of those answers, it would have been somewhat right. It really depends on the situation. But if you're particularly looking for a patient with a chronic illness, particularly dementia, it can be as much as 5 years or longer. And when you kind of wrap around that, how long that really is, and how in some ways it can be so unsustainable to do primary caregiving for someone who has a lot of needs for that long. It can really and they collapse. Those situations collapse as the caregiving needs get more and more. And so it's just understanding where people are in their caregiving stories. It's very important to remember to ask about it. So next slide. I just want to talk a little bit about the sandwich generation. I did mention it in one of the other slides, but it's really this confluence of having full-time work, doing childcare, doing elder care all at once. I think, if anything, during the pandemic, this has gotten families shifted around. This has really gotten worse. Next slide. And the effects, we'll be curious to see how people are surviving, how people have survived this, and what comes of this, and what lessons we can garner from this situation that we're in, where people are just forced to in these multi-generational situations where you might have one person doing tons of caregiving. It's just good to recognize when you're working with families. Just ask, like, what's your family situation like, just so you can get a sense of it. And when you look at the data again, it's just about half people have jobs, and then on top of that are doing ADLs for somebody in some version. And those tasks, there's a huge range of things people can end up doing, and it could be simple things like just filling a pillbox or driving someone to an appointment, but it can also be being responsible for sort of the totality of their bodily needs. Like, the range is just huge, and the system doesn't capture that well, like on an individual scale, what actually people are doing and how to respond. Next slide. How many people miss work? Everyone take a guess about that? Okay, what do people think? Nobody misses work. Everybody misses work. Yeah. And I think, the hard thing about this is, you can go to the next slide. We don't really suffer our colleagues when they were in these. I'm not sure we do that well with that when we have a colleague who's out a lot to caregive for a family member. This system just doesn't have the flexibility for it. And if you've been in that situation, you can feel sometimes the resentments or things happening in your workplace if you're trying to get out because you have to take your parent or someone to an appointment or something. It's not well received. And the potential for it, and this what I put up here is actually, there's a very excellent paper about this topic that I put the reference up for you. So if you are interested to really, if you want to dive in to this aspect, to take a look at this paper, it's quite good. Next slide. This is from that paper, and they listed all the laws related to, employment discrimination, and caregivers are not sometimes specifically named, but they're sort of embedded in the ethos of all this. But in reality, it's actually quite hard as an individual to leverage any of these laws. And in the only situation, sometimes if you're in a union, and your union knows this and can advocate for you. Otherwise, we have a lot of laws, federal laws, how they play out in individual states is very varied. So we have these laws, but I think from trying to really leverage them for your patients is quite difficult, or even for yourself. Next slide. So I just want to sort of go into assessment a little bit. I think, we have a lot of people on this call, I am certain, are like masters at assessing. You can do it, especially if you're using a tool. I would say it's the easier part is to get through this. The way harder part is actually having, dealing with it and having something to offer to your families. I think that's when it can get very hard. And the thing to note, if you are a social worker or case manager on this call, like, it takes a lot. You have to train your docs actually to make these identifications. They won't always. So we're actually not well trained in doing assessments, and we've been sort of convinced that it's not our job to do these assessments. It's someone else's job, but that's so not true. And it's always right under the medical. It's right under there. And if you're not bringing it and using these needs of caregivers, if you're not integrating them into medical plans collapse over not meeting caregiver needs. And I think the more you can do to educate your partners in all this and bring them along with you, I can tell you 100% everything I know about family caregiving I learned from my social worker, case management, chaplain partners, that because I'm a palliative care doctor on my team, we all work very, very closely together. So that's how I learned. But a lot of doctors are in a bubble that don't have this access to partners as rarely. So I just want to really encourage you to do that. Next slide. This is a little bit of a digression, but I think the reason I'm bringing up HIPAA here is because HIPAA can be so weaponized against caregivers. I think we can do it unintentionally, thinking that we're sort of protecting the institution or protecting the patient. But in fact, I've seen it used so poorly, in hospital settings. When my mother was 92, and I would just up against HIPAA sometimes. I was just like, can you just please talk to me? But HIPAA is meant to protect medical information from unauthorized users, employers, and marketers. It's not meant to just block out everybody. And I think that's where it can get very, very complicated with caregivers. If you go to the next slide. So HIPAA does not prevent healthcare providers from sharing patients' private medical information with family, relatives, and friends. It doesn't prevent you, and particularly if that person has been identified as involved. You don't need to leverage that, and you don't need to be a healthcare proxy either to get information. And if the patient is like, this is my son, you can talk to him, and that's been acknowledged. You can do that. And I just want to encourage you, and you can go to the next slide, that, what do you know what your HIPAA policies are at your institution, and have you leveraged, if you made them even worse than they need to be? And if you're an administrator on this webinar, to just kind of say, well, what are we really trying to achieve with our HIPAA, and are we blocking caregivers in a way that's not good for the patient, not good for the caregiver? But HIPAA doesn't require a release, like it doesn't do that. And I've seen these just situations spiral out of control with people not, giving passcodes and all kinds of stuff. So it's just something food for thought for your community health center. This also can be particularly bad. These are the references for that also. If you have non-traditional family partners, non-traditional caregivers get snarled in the HIPAA thing, and LGBTQ partners, for instance. Everybody can get really confused with all this. So I want to encourage you all to just look at what you're doing in your institution, make sure you're all on the same page about it, and that you're not overstating the law, actually. Next. So we don't actually ask we don't ask caregivers very much, and I know that was the case with me as a caregiver. People didn't really ask me, how I was or what I needed. Not very often, I'll have to say. And it's a missing part. It's an invisible part of the equation. So I guess, I just want to explore that just a little bit. Like, why don't we ask? I think, also we tend to, it's a natural part. We tend to be a little bit on the prescriptive side as providers. Like, we find out what the needs are, and then we want to prescribe. But we're not as good as saying, well, what actually do you need? What actually do you think you need as to a caregiver? And then trying to work with that, we tend to think, okay, I see this need, I'm going to fix it. And that sometimes can be met with a lot of resistance, or just not quite the right fit for that particular family. Next. Just take some time to identify caregivers. I'm going to talk about this a little. It seems so silly, right? But in fact, we actually don't always know who the caregiver is. Like, you can have the daughter, out-of-state daughter, who's the proxy, but then the live-in boyfriend who's actually the caregiver. In my mom's case, my mom had a 92-year-old boyfriend. She was 92. Well, she had her boyfriend for like 10 years, but he was a caregiver for my mother, but I was my mother's healthcare proxy. So how do you work that out as a provider? Like just at least just to know who's in the house and who the players are, and not to just draw on our caregivers in when there's a crisis. That's often what happens in the family. We really do expect caregivers just to show up and deal when patients are in the hospital, but they often could be the first time they're interfacing with providers is in a crisis situation. So if you're in the community and you have opportunities to draw caregivers into regular medical visits, that's only going to serve you well and serve the patient well in the long run. Next. Sometimes patient may not see themselves as having a caregiver. My mother, if you asked her, who's your caregiver, she had dementia. She would be like, I don't have a caregiver. I have my friend Natalie who comes to see me, who comes to spend time with me, but the paid caregiver, but she wouldn't necessarily know that. And also, if caregivers themselves may not see themselves in that role, they don't understand the role of being a caregiver. They just see themselves as the daughter, the wife, the son, whatever, and they don't recognize it. So it's up to us to kind of help families along to understand that they actually have a real validated role in the patient's care and to acknowledge it as such. I think this is a great place to start. It's just acknowledging caregivers more than we do, and to get your docs to do it as well. Next slide. So just ask, take a social history. I mean, it's, the idea of a social history, the doctor's social history, and it's mainly in the chart for billing purposes, is to ask about tobacco and alcohol, but it doesn't really dig into a social history. But a social history is one of the most interesting and valuable things you could do and get into the chart properly. So just take a social history. You'd be amazed what you'll learn about your patient by asking them. Next. This is actually, I put this one up because this is actually my family. And this is my stationery because I like crabs. I don't eat them, but I think they're interesting. But I'm not going to go through this very much, but just to say that a caregiver network can be actually quite complicated. And, in our case, we had as I was saying, we had the boyfriend. He drove my mother. That was a whole other can of worms. I had my sister. I had my other sister who was managing finances, and it was a POA. There was me. I was the first response medical daughter that lived very close. We had professional caregivers, so there was a real network doing different jobs. And what happens in the chart is you can have a place for an emergency contact and possibly a healthcare proxy in your chart, but there's no place to put this information that gets translated through your institution in a way that you can act on it. So that's just another area that if you're trying to try to improve communication and what's happening with caregivers, is to try to create making sure you understand what their network is and how do you communicate that to each other. Because that can get tricky, and it can get messed up. We just had constant problems with people, communication over who is doing what with caregivers. Next slide. Here's just a list of open-ended questions. I always say, when I started working with families, I actually just memorized some questions and had them at my fingertips just to remind myself to ask them. And actually, what has hit you hardest? That question that's a question Joe Biden. I saw him ask that to a caregiver on an interview like that he was on, and I was like, that's a really good way of putting it. Like, what's hit you hardest? So I put that on the list. So these are just some questions to think of. Write them down and just have them around so you remember. You might remember. You might be one of those people that remembers to ask this, but it's amazing how we don't. Next slide. Just some more questions. These are more like a little bit less open-ended, and it can get tricky to ask people about, if they're seeing a doctor and so forth. They could maybe close down with this kind of question, but just ask anyway and see what kind of feedback you get from people, whether they're willing to talk to you about that. I think the hardest thing about asking these questions is then, do you have to do something about it after you've asked it? Because I know on the physician end, you can feel so helpless. Like you can get you can ask a question about how you're doing, and then they'll tell you, and then you're like, oh, now what do I do? Because the system doesn't allow us to access very specific ways to help sometimes, and sometimes it feels better just not to even ask. And I know that I'm giving you sort of the honest experience some of us have about trying to delve into these things and also having the time. Next slide. Okay, I put this up here because this is a word cloud. I used to use these all the time in family meetings, particularly if a family was at the point where they trusted me, but they couldn't make decisions. And this came up a lot with end-of-life decisions, and they would just sit there not saying a word. And I just found it very helpful to make a word cloud, which you can do in 1 minute with the free program online. But I would just ask them to come up, for instance, with just descriptors about who, if we're talking about a family member, like what do you think, tell me about this person, what do you think is most important to them in their lives, what would they say if they could be here? I would just give ways of them to come up with words, and then I'd make a word cloud for them. I'd sometimes print it out, and then say, we'll talk again in a few days. And it's amazing how that can help, but particularly if you have a family that just can't wrap around concepts. So I just want to encourage you to do word clouds. It's a handy tool. Just validate. It's amazing how we forget to do that. We can be very, at least in the hospital setting, I won't say this is true in a community health center, and I'm making a generalization, but we can be very judgy of families. And if from a physician perspective, I won't speak for every physician, but sometimes we are great with families when they agree with us and they agree with our plans, and we are not so great with them when they don't agree with us. And I've seen that play out, and where families can get vilified. We don't recognize them. We see them as obstructing plans, not taking the patient home. A lot of things. I've seen it play out in so many forms over the last 20 years. So if you're on a team in the community center, just stop and say, has somebody just told this person they're doing a great job? Sounds simple, but it's a great thing to do. Okay, so these are just, I put this list up for you. This is from the Center to Advance Palliative Care. This is actually a free access. So you can just go on their website, and then you have a list of it's under their dementia care. You can look at these assessment tools. Word of caution with assessment tools. I have years and years of experience of implementing assessment tools because I was in a leadership role in palliative care in my institution. And just be careful what you wish for with an assessment tool. Take your time, if you're in leadership, to actually look at them and make sure that the people who have to use this assessment tool are have input and are giving you feedback about whether it's doable, whether it's taking too much time. And what it means. So assessment tools are incredibly valuable, but you have to really take the time to decide which one works for your setting and the people who are using the assessment tool to make sure that it's doable in their workday. And then once you've done this assessment, what is the pathway to act on what you find? Because you can go down a real rabbit hole, and that's where you're going to get in trouble, where you've identified things, but then you just don't do anything about them. So assessment tools are great. I highly recommend them, but really just take your time when you're picking one. But I highly recommend that you go on the site and just look through these if you're not already using an assessment tool. Next slide. Okay, so I put this one up just because you want to make sure that there's some kind of red flags that are going to put some families at a lot more risk than others. And you might say, oh, this is everybody at my center has one of these problems. And that might be true. But you want to try to dig in. And if you identify something that's particularly difficult, for instance, if you let's say you have a caregiver who is an adult disabled child, actually, so you can have a caregiver who is an adult disabled child who's giving care and getting care. And how are you going to support that person? Like there's some specific situations which are much worse to deal with, especially when you're dealing with them in crisis. And social workers, I think, are really, and case managers really at the point to dig into these things, but it's how you bring it up into your group and how you get your prescribers, for instance, how you get them to sign off on papers that actually support these kinds of situations. If you get one thing from this talk, and I'll say it again at the end, is if you're not already in a partnership with a public interest law firm in your community, you should try to get one, because it's one of the most useful things that you're going to do in terms of getting things done for caregivers, is to have a public interest law firm involved in a case, particularly if benefits are being disputed and you need a lawyer to go to court for somebody. So if you're not already involved with a public interest law firm, you should consider it. I found it to be one of the best tools that I had in my toolbox is when I entered something called a medical legal partnership, actually. So next slide. Okay, the intensity of caregiving can really be defined by a lot of factors. I'm not going to go into this in great deal for this talk, but it's just what I want you to get out of this is just that the range of intensity can be huge and it can change really quite abruptly. Next slide. Why is it so difficult? Like family caregiving has some parts of it that are so different than other things that we do. One, it can be very unpredictable in need and duration. And our healthcare system really doesn't always account for that. Like it doesn't flex when we have unpredictability in what we need to do. And the other thing I think that's been brought also may come to light with the pandemic is the intense sense of isolation that people can experience, particularly in a caregiving role, that's sort of with this underpinning of grief and loss. So if you're taking care of someone who's very sick, chronically ill, you're living with someone who's kind of disappearing before your eyes to some degree. And now with the pandemic in particular, some of the things that might give you a bit of joy with that person, like getting them going out to lunch with them a couple of times a week, or having a friend, or one of their good friends come over, or having a grandchild visit, things like that. Those have gotten so lost. So you can have people literally trapped in their houses with doing caregiving in these incredibly isolating ways. And I've just worried endlessly about this situation, and hopefully this will lead to better policy in the future. But I think that's where we are with things. Next slide. The other thing, we just have such high expectations of families, and we never really contemplate what we're asking families to do. More and more, you can find yourselves having to deal with tubes and drain and feeding and complex pill regimens and incontinence and behavioral issues, and you're this one person or maybe a couple of people trying to manage someone, and we assume a lot, and we just really expect people just to step in, and a lot of times people just don't even know what they're agreeing to, and then they find themselves alone dealing with things and not being able to afford things that we just expect them to be able to get. Like, for instance, adult diapers. We send people out of the hospital that are incontinent, and then families have to pay for adult diapers, for instance. I think we think home care services is there all the time, but families don't understand that you might get a visit for a short period of time that might help you a little bit, but it's not going to be there 24/7 for you. And it's not the same as, home care services won't necessarily meet that need. So I think we just should be mindful of what we ask our families to do. Next. This is actually my word. I put there's two slides, and I just made a list. It's actually how I made my word cloud, because when I was putting together this talk and I was thinking about my own experience with caregiving with my mother, just how many strains there are and how many impacts there are in families. The one I want to just bring to your attention, in addition to the sort of physical demands on people that can be involved in a family caregiving, just go to the next slide also. If you're doing assessments, to not forget that the substance abuse issues that can be mixed in terrible ways in these situations, particularly now, there's definitely been a rise in alcohol use in older persons, and if you're not sort of thinking about it, particularly finding ways to assess this both in the patient and the caregiver, the amount of alcohol that's in the home and how that's impacting caregiver, what's happening to them. I think elder abuse, I think social workers always have their antennas out for that, but I think the pandemic itself, I just think the potential for that to happen in people that normally wouldn't strike or abuse is just gotten high, and it's just unfortunately something we really just have to consider all the time. Next slide. Okay, there are some joys. It's just, I know that me personally, with my mother who died in June after about 10 years of pretty intense caregiving for my family, it was just that when I look back on the experience, I do consider it something that I'm very glad that I was able to do. I think to bring that out when in your conversations, to just ask someone, what parts of this give you joy, what does it mean to you? And for yourself, if you are a family caregiver yourselves, what it's actually going to mean to do caregiving, because it can be a beautiful thing as well. And just not to forget that we tend to focus in on the problems quite a bit, but not on what's working and what's joyful about it. Next slide. I just put this up. This is from that same AAR report, and not to read this whole slide, but it's just there's this sort of no choice caregiving where you have people who have been really trapped, who just feel like they have no choice but to be a caregiver, and those caregivers tend to not do so well with their own health, and they can really unravel quite quickly in these caregiver situations. So if you're assessing someone and you haven't sort of sussed out, because it can be hard for someone to say that I feel trapped, I have no choice, to sort of find out where they are with things, whether they feel like they have an exit strategy or whether they're hemmed into, because these people just don't do so well with caregiving. It's just something to realize. Next slide. Showing you get it, that's a big part of it. Sometimes when I don't know what to do, I just will sort of say, well, I just want to make sure I understand what the main issue, help me to understand. It's a great phrase. If you don't use this all the time, just help me to understand. It's a very empathetic way of clarifying. And also, if you're not quite sure what to say to someone yet, how to respond, it's really always helpful to say, just let me make sure I understand what you're telling me and what's really hard for you and what's working for you. You'd be surprised that just that act of doing it that way can really create a trust environment that might be hard, can be sometimes hard to achieve. So help me to understand. Next slide. These are the things a lot of people worry about, is like, how am I going to get help? Who's going to help me? How much it'll cost? You should just, even when they don't ask, they're thinking about it. So if you're, dealing with a family, just to say, are you worried about funding for this? How are you getting help? Are you getting help? Those kinds of questions. And sort of try to bring that out to see if you can do an intervention. Next slide. Families, like if I had I should just have if I had $1 for every time I had to say to a family, no, that's not covered, I would just be so rich, because most things are not covered. And I think families have real shock when they don't realize how little is covered to actually do particularly custodial care and so forth. So in the community, giving people good education about what's paid for and what's not early, and not waiting for when they're in the hospital, which is when I get them, about this is really valuable to educate families, to have educational materials about how they need to plan. Next slide. How are you really going to help, though? And I think the most important thing is to really understand where people are in disease trajectory. And I'm not going to talk about that a lot, but just we'll talk about it a little bit more in the next one or two slides. So just go ahead. Okay, and what that really is documenting functional history, and anyone on a team can do that. But you really want to get your doctors and other nurse practitioners, to document functional history, because that's going to help you with paperwork down the road in terms of getting people services. And if you're the social worker or the case manager on the case, to sort of loop back to your prescriber to make sure that they understand that they need to put these things in the chart, and to sort of help them with the paperwork a little bit, because I know I used to get very out of sorts about doing paperwork when I was I did primary care for probably 8 or 9 years before I was palliative care, and I hated it then. When I was a palliative care doctor, I used to do paperwork for other doctors all the time, because I finally understood how important it was to get people services. So if you're and then also, if you have a public interest attorney that you're working with, they can help you have the right wording and paperwork and using functional history so people actually get the services that they need. It can be very tricky from state to state. You can have a situation where you have a caregiver at home, and then you'll get a nurse who will come assess them for how much they're going to get through a Medicare or whatever it is in their state. But they may say, oh, I see you're doing a lot for your mother, so you don't really need too many hours, do you? Because you're here. So there's this sort of undertow from the system that's looking to give less, not more. And if, as an individual care provider, if you're not aware of that and sort of saying, look, when they come, just say you can't do this anymore, that you need help. Make sure you say that, because otherwise, that the person might not get the care, and then it ends up getting into a dispute and you get denials for care. So it's just these little, I'm not going to call them tricks, but you should just be aware that the system itself is not necessarily helping to maximize care for people. And unless you understand that, you can end up not really helping people. Okay, next slide. I'm just going to tell you document. And these early, I'll say financial legal assessments, everybody thinks about getting a proxy and a surrogate, and that's important. But to me, it's not nearly as important as financial planning and seeing where people are doing that early. In my family's case, it took so long to get my mother to agree to anything. And you can do the next slide. I think it took us 5 years to get her to name a power of attorney for finance. It took 5 years, I want to say. And really, I consider this the most important document that people can have in place. And people are very resistant to put down someone as a POA. They might not want to do that. They might not want to talk about their finances. It's a very tricky area. So it takes time. And then also understanding why people need to do it. And that's where the education piece comes into all this. So you really want to try to do this early. Next slide. Okay, so there is some time. I wanted to try to leave a little bit of time to see if people have questions, and here are some of the things just to remember to get at their real story, their network, and to do these assessments, and then understand who your community partners are, so you can actually help somebody through partnerships. And I'm just going to stop now. Does anybody want to throw out any questions about all this?
Great. Yeah. Thanks so much, Dr. Hallerman. We have about 10 minutes or so. I know that for folks who responded to the poll questions, there weren't too many in the group who either in the past or currently are caregiving, but I'd be curious to know if there are questions around, patients that you've interacted with who've had who are caregivers and how you can support them. So we have some great time for discussing anything that Dr. Hallerman brought up or anything that's on your mind. So we'll give it a few minutes for folks to both utilize the chat or the Q&A feature. I will say that we can, in the follow-up email that we send with PDFs, we can include one of those CAPC resources that was mentioned around the validated assessment tools. We can definitely take a look at that. I'm not able to see the Q&A feature, I think, because I'm sharing my screen. Julia or Tiff, can you help with that?
Sure. We have a comment from Yasmin who said, "Thank you for this. We talked to our members about how important it is to be updated on these laws and regulations in order to advocate for yourself in the workplace. It's so crucial.
Mm. Oh yeah, I think that yeah, that was an earlier comment. I forget what slide, Lynn, but early on.
Yeah.
Mhm. Are you able to see Tiff in the actual Q&A? I see that there might be two questions, but I'm just not
Yeah.
able.
One of them says, what kind of technologies are out there that can help caregivers navigate resources? Um, I think if I had to make one recommendation, I would tell people to go on to AARP. And I have no financial connection to them, by the way, so I'm not getting any kickbacks by mentioning them. But they actually they have huge amounts of resources. They have a 24-hour hotline, actually. I did put a couple of resources, references in the if you look at the references for the talk, I don't, there's the family caregiver, caregiving.org. They're really wonderful also. I know that for people sort of in sort of the crunch of caregiving, sometimes they just don't even know how to access these resources and use them. So if you, in your community health center, if you can kind of facilitate getting people onto these resources and helping them utilize, that's another area where you can really help people a lot, is just sort of guiding them through resources, because it can get really overwhelming. And I know when I was personally, even as I'm a palliative care doctor, I was still overwhelmed with trying to navigate resources and trying to figure out things that my mother qualified for and who can help us. And it's very, and I've just found also caregivers can be so frayed, emotionally frayed. You give them one form to fill out and they just melt into like a sea of tears. And I know I felt that way a lot. So it's just something to keep in mind. But AARP has tons of stuff.
Yeah, I see a comment, and I know we still have a couple of them in the Q&A that I apologize that I can't see, but Tiff or Juliet can help with that. I also see I used to work for a private home care company, and finances are a huge problem for most families. And we definitely we had a learning collaborative this fall around supporting family caregivers of older adults with dementia, and that definitely came up. Jess continues to say a lot of families have invested in long-term care policies that don't want to pay. What is your best advice on finances for future care?
Oh, I wish I had the answer to that, because it's just an impossible. It's you have either self pay, you have situations where someone does a spend down for Medicaid. I think there's a group of people sort of in the middle who do not qualify for Medicaid and who do not have a pot of gold at the end of the rainbow to finance caregiving. And it is a very hard situation, and that's where the unpaid family caregiver sort of is just sort of expected to step in. When that collapses, it can collapse in really tragic ways for people, where people end up in sort of being jettisoned from their communities, from their families, into hospital, into institution that isn't quite right for them because of that. But I would say the more information that we give to people around this early, and not to wait. So in your own organizations, to make sure that you actually have a way, sessions about financing, and just so people understand what's paid for, what isn't. Long-term care insurance industry hasn't been doing all that well. Actually, a lot of those places have gone bankrupt. I know for insurance for long-term care, it's very expensive. There's a huge period, 90 days, so it often doesn't even help people unless they need enormous amounts of ADL. So no, I don't really have the answer to all this, frankly. I wish I did.
We have another question in the Q&A that is, are there any charts or graphics that present a timeline, generally speaking, as to when family members can expect to begin their caregiving responsibilities?
Oh, that's a really good question. It's funny. I didn't put in my trajectory chart on this talk. I usually do. Like Ariel is very familiar with but my answer to that is the thing that you can do that's going to be most helpful to sort of explore when that trigger that they're becoming not just a partner but a caregiver, is to look at the patient's function, and that's what they can do on their own, what they need assistance for, And you can drill it down. There's lots of good functional assessment tools out there to use that are much actually easier than the ones that I showed for caregiver assessments to use, where you can look very specifically at people's ADLs and see where they fall in their ADLs, and that's going to give you the best information about when someone needs caregiving. It's about function. If you're waiting for a doctor to give a prognosis, that's a kind of useless thing for actually starting caregiving, because that can be a hugely varied thing. So I would say to you is to ask about what the person needs assistance for, dressing, bathing, feeding, what they're doing. That's going to be your best guide for that.
Mm-hmm. Yeah, I see that we have a comment, someone reflecting that they work with a hospital setting and they've witnessed situations where it looks like family members might not be able to take on all of the responsibilities to care for their family members. And certainly I think that speaks to some of what you were saying, Dr. Hollerman, around having those conversations early, or maybe seeing that, maybe it got too much because there wasn't enough support. I mean, certainly the situations could vary. I wanted to know if you had any reflections on that.
I have seen so many families who are really doing heroic work. They're doing for long periods of times, and then it gets to the point where they just can't handle it, and the patient will decompensate into the hospital, and then then they're like, I can't do this anymore. Those are sad situations, and the really even more sad situations I've seen is where people are coming in without having any family support, or families that have not done any power of attorney for finances. They haven't done any of that, and then your patient loses capacity to make medical decisions or financial decisions, and then you have to go through a guardianship in the hospital to grant guardianship to somebody, and those situations can be so painful, so difficult for families, so dignity stripping and difficult for patients themselves. So the more that can be done, to plan out this in the community, the less likely that's going to happen. Where you have these situations that have been totally unmanaged, and people have no idea what to expect. So it's a big lift for community people, though. That's the problem, is it's a very heavy lift. And I do not think one provider can do this. I think it really takes a team. So as a community health center, it's really sitting down with your group and saying, what can we do? What can we handle? And on that note, I believe, there's going to be a series on PACE coming up that you might want to consider joining, because it really does try to look at how to support the very frail in PACE programs in the community that try to anticipate all this so you don't have these crisis hospitalizations. That's coming up in April, I believe.
Yes, absolutely. And get Dr. Hollerman to have her expertise in that learning collaborative as well. We are going to wrap things up. Now you will receive an email from us with our slide deck and a link to our YouTube page where the recording of this session will be. We will also be in touch about future training and technical assistance opportunities that does include the PACE Learning Collaborative in the month of April. You can check out the details around that on our website. Like we mentioned at the start, when you close out this Zoom window, you will automatically get sent to an evaluation. We'd love for you to take just a moment or two to give us your thoughts. That helps to shape future training sessions. We thank you for your time and participation, and thank Dr. Hollerman for her expertise. We hope that we'll see you in a future training soon. Take care and have a wonderful rest of your day.
Thank you, everybody. Bye-bye.